Scenario Challenge. This is Season 3, Episode 1. Today, we have Rogers, a dedicated medical student, joining us to tackle a clinical case and test his knowledge. Let us dive right into it. Rogers, in today's scenario, you are presented with a 36-year-old woman, Agravita 9, Para 8, who has come to the BO2 clinic at the Women and Newborn Hospital. She brings an ultrasound scan report that reveals a twin pregnancy, with the presentation showing a characteristic T sign. I am going to ask you a series of questions related to this scenario, each worth specific marks. Answer them thoroughly using medical terminology. First question, Rogers. Based on the T sign on the ultrasound, what is the chorionicity and amnionicity of this twin pregnancy? 2 marks.
The chorionicity and amnionicity of this twin pregnancy are monochorionic and diamniotic.
Good. Now, tell me, what is the zygosity of these twins? 1 mark.
The zygosity of these twins is monozygotic.
Excellent, Rogers. Moving on to maternal complications. Could you list 6 maternal complications associated with multiple pregnancies? 3 marks.
Certainly. 6 maternal complications associated with multiple pregnancies include 1. Preterm labor 2. Nutritional anemia 3. Postpartum hemorrhage 4. Operative delivery 5. Pregnancy-induced hypertension 6. Malpresentation.
Well done. Next question, what fetal complications can arise as a result of this particular chorionicity? 2 marks.
Fetal complications that can occur due to monochorionicity include 1. Twin-to-twin transfusion syndrome, also known as TTTS2. Twin reverse arterial perfusion syndrome, or TRAPS 3. Twin anemia polycythemia syndrome, or TAPS 4. Discordant growth 5. Single fetal death 6. Cord entanglement.
Great response, Rogers. Finally, can you give me 2 reasons why this patient is at an increased risk of postpartum hemorrhage? 2 marks.
Yes, 2 reasons why this patient is at a higher risk of postpartum hemorrhage are 1. Uterine overdistension, which compromises myometrial contractility and increases the risk of uterine atony. 2. The mode of delivery, as a caesarean section, has an increased risk of bleeding.
Thank you, Rogers, for those well-structured and accurate answers. You have demonstrated a thorough understanding of the clinical complications associated with twin pregnancies, specifically with monochorionic diamniotic twins. This concludes our first episode of Season 3. Excellent job, Rogers, and thank you to everyone watching. Join us next time for another challenging case on the Doc Scenario Challenge. Welcome back to the Doc Scenario Video Challenge, Season 3, Episode 2. In this episode, we will be working through a complex clinical presentation in the labor ward. I am here with Rogers, a medical student, who will help us analyze this case and walk through the answers step by step. Let's get started. Rogers, here is the scenario. Mrs. Megabytes, a Gravita 7 Para 6 woman at 34 weeks gestation, presents to the labor ward with a 4-day history of dysuria, abdominal pain, nausea, and vomiting. On examination, she is febrile with a temperature of 39.2 degrees Celsius, a pulse rate of 120 beats per minute, and tenderness over the right renal angle. This case is worth a total of 10 marks. Rogers, for the first question, worth 2 marks, based on the information provided, what is your working diagnosis?
My working diagnosis is a urinary tract infection.
Thank you, Rogers. Moving on. Next question, also worth 2 marks. Can you give me 2 reasons why pregnancy predisposes Mrs. Megabytes to this condition?
Pregnancy predisposes her to a urinary tract infection due to urinary stasis and incomplete voiding. These factors can contribute to the presence of residual urine, which allows bacteria to multiply.
Good reasoning, Rogers. Now, question 3, worth 3 marks. Name any 3 microorganisms that commonly cause this condition.
The 3 microorganisms commonly responsible for urinary tract infections are Escherichia coli, Pseudomonas species, and Klebsiella species.
Great. Now, for our final question. Rogers, for the last question, worth 3 marks, What bedside and laboratory investigations would you conduct to confirm this diagnosis?
The investigations I would perform include a urinalysis, urine culture, a full blood count, and renal function tests. Additionally, I would consider imaging studies to assess for complications, and possibly a cystoscopy if necessary.
Thank you, Rogers. That was well done. You have answered each question comprehensively with clarity and a strong understanding of the clinical aspects involved. That concludes today's Doc Scenario Video Challenge, Season 3, Episode 2. Join us next time as we continue to work through more challenging clinical cases. Thank you for watching. Hello and welcome to Season 3, Episode 3 of the Doc Scenario Video Challenge. Today's case will address a commonly encountered gynecological issue that requires a methodical diagnostic and management approach. In this episode, I am joined by Rogers, a medical student who will help tackle this case with us. Today, we have a 40-year-old patient, Mrs. Chanda, presenting to the gynecology clinic with complaints of very heavy menses for the past 4 months. Her periods are irregular, and she uses up to 18 pads a day. She also reports feelings of weakness and dizziness, and she has 4 children. Rogers, I will ask you a series of questions regarding this case. Each question carries specific marks, so please answer comprehensively. Rogers, let us start with our first question. What investigations would you carry out in this patient? This question carries 4 marks.
Thank you, Doc Scenario. For Mrs. Chanda, I would carry out the following investigations. 1. A full blood count to evaluate for anemia due to heavy menstrual bleeding. 2. A pelvic ultrasound scan to assess for any structural abnormalities, such as fibroids. 3. Thyroid tests to rule out any thyroid dysfunction that could affect menstrual regularity. 4. Coagulation screening to investigate any underlying bleeding disorders. 5. An endometrial biopsy, especially considering her age, to rule out any endometrial pathology. 6. High vaginal and endocervical swabs to detect any infections that might contribute to abnormal bleeding. 7. A hormonal profile to evaluate hormonal levels that could explain the irregularity and heaviness of her periods.
Very well structured, Rogers. That would indeed cover the likely causes of Mrs. Chanda's symptoms. Now, for the next question, please outline the various options available for the management of this patient. This question carries 6 marks.
Certainly, Doc Scenario. For Mrs. Chanda, the management options include both medical and surgical approaches. 1. Medical options. Levonorgestrel intrauterine system. This option can help reduce mean blood loss during menstruation. Tranexamic acid. This can be taken specifically during her menstrual periods to reduce blood loss. And mefenamic acid may also be an option. Norethisterone, a progestogen that can be taken at 15 mg daily in a cyclical pattern, from day 6 to day 26 of the menstrual cycle, to help regulate her cycle and reduce bleeding. 2. Surgical options. Given her age and parity, surgical interventions could be considered. Endometrial ablation. This procedure uses heat or radiofrequency to destroy the uterine lining, which can significantly reduce menstrual bleeding. Myomectomy, a surgical option involving the removal of fibroids, which are a common cause of heavy bleeding. Hysterectomy, as a definitive option for women who have completed childbearing and seek a permanent solution to heavy menstrual bleeding.
Excellent, Rogers. You have covered the management thoroughly, addressing both the medical and surgical options relevant to Mrs. Chanda's age and symptomatology. Thank you for joining us for Season 3, Episode 3 of the Doc Scenario Video Challenge. We appreciate Rogers' insight and detailed approach to this case, showing the importance of a comprehensive assessment and tailored management plan. Stay tuned for the next episode, where we will continue exploring real-world clinical scenarios. Welcome to Season 3, Episode 4 of our Medical Dialogue series. Today, we will discuss a crucial condition in obstetrics, preeclampsia. We will follow a case scenario that illustrates the significance of early recognition and management of this condition. Joining us for this discussion is Rogers, a dedicated medical student. Let's dive into the clinical scenario. Rogers, Today we have a case involving a 20-year-old primigravida who was referred from a clinic due to significantly raised blood pressure of 180-110 mmHg and 3+ proteinuria at 30 weeks of gestation. Let's start with the first question. 1. What are 5 central nervous system, including ophthalmic complications, that can arise in a patient with preeclampsia? 2.5 marks.
The complications of preeclampsia that may affect the central nervous system and ophthalmic health include 1. Cerebral edema 2. Cerebral hypoxia 3. Retinal hemorrhage 4. Retinal detachment 5. Papilledema.
Excellent, Rogers. These complications can have serious implications for both the mother and the fetus. Now, let's move on to the treatment of hypertension in pregnancy. 2. What is the mode of action of 4 commonly used drugs to treat hypertension in pregnancy? 2 marks.
Certainly, the modes of action for commonly used antihypertensive drugs in pregnancy are as follows. Methyldopa, this is a centrally acting antihypertensive that functions through alpha-2 agonist actions, effectively reducing sympathetic outflow. Labetalol, this medication acts as a non-selective beta blocker with additional selective alpha-1 blocking properties, helping to lower blood pressure. Nifedipine, a calcium channel blocker of the L type, it inhibits calcium influx into vascular smooth muscle, leading to vasodilation. Hydralazine, this is a direct arteriolar vasodilator that decreases peripheral vascular resistance.
Great job, Rogers. These medications are essential in managing hypertensive emergencies in pregnant patients. Now, let's discuss magnesium sulfate. 3. Why would magnesium sulfate be used in this patient? 2.5 marks.
Magnesium sulfate would be administered for seizure prophylaxis in this patient. Given her elevated blood pressure and proteinuria, she is at high risk for developing eclampsia, and magnesium sulfate can help prevent this life-threatening condition.
Thank you, Rogers. Finally, let's cover the safety of magnesium sulfate administration. 4. Under what 3 circumstances should the dose of magnesium sulfate be withheld? 2 marks.
The dose of magnesium sulfate should be withheld in the following circumstances. 1. Loss of deep tendon reflexes, indicating potential toxicity. 2. Respiratory depression, which may compromise the patient's ability to breathe effectively. 3. Reduced urinary output, which can signal impaired renal function and increased risk of magnesium accumulation. 4. Reduced heart rate, as this may indicate significant cardiovascular effects of magnesium toxicity.
Well done, Rogers. Your answers highlight the importance of monitoring and the potential complications associated with magnesium sulfate therapy. Thank you for joining us in this episode. Understanding preeclampsia and its management is critical in obstetrics. Stay tuned for our next episode, where we will continue exploring vital topics in women's health. Until next time, keep learning and stay safe. Welcome to Season 3, Episode 5 of our Medical Dialogue series. Today, we will explore an important topic in gynecology, uterine fibroids. Joining us is Rogers, a dedicated medical student who will help us navigate this case. Let's begin with the scenario. Rogers, we have a clinical scenario involving a 30-year-old woman who presents to the gynecology clinic with complaints related to uterine fibroids. Let us start with the first question. Question 1. 1 mark. What are uterine fibroids?
Uterine fibroids are benign tumors of the uterus that develop during the reproductive age of a woman.
Thank you, Rogers. Now, let's move on to the next question. Question 2. 3 marks. Could you broadly classify uterine fibroids?
Certainly, uterine fibroids can be classified as follows. Intramural fibroids, which develop within the muscular wall of the uterus. Subserous fibroids, which grow on the outer wall of the uterus. Submucous fibroids, which protrude into the uterine cavity. Cervical fibroids, which occur in the cervix. Parasitic fibroids, which are attached to the uterus but have their own blood supply.
Excellent classification, Rogers. Let us proceed to the next question. Question 3. 3 marks. What are 3 risk factors associated with uterine fibroids?
3 risk factors for uterine fibroids include nulliparity, or having never given birth, obesity, which increases estrogen levels, race, as studies show that black women are at a higher risk.
Well noted. Now, let us delve deeper into one of the symptoms. Question 4. 2 marks. Menorrhagia is one of the symptoms of uterine fibroids. How does it occur?
Menorrhagia, or heavy menstrual bleeding, can occur due to several mechanisms. There is an increased surface area of the endometrium because of fibroid presence. Abnormal mechanisms of uterine contractility may also play a role. Congestion and dilation of the endometrial venous plexus due to obstruction can contribute. Lastly, endometrial hyperplasia may result from the hormonal influence of the fibroids.
Thank you for the comprehensive explanation, Rogers. Now, let's move on to the next question. Question 5. 3 marks. List 3 important investigations for uterine fibroids.
3 important investigations for diagnosing uterine fibroids include ultrasound, saline infusion sonography, magnetic resonance imaging.
Thank you, Rogers. It is essential to identify any complications associated with fibroids. Question 6. 3 marks. What are 3 complications arising from uterine fibroids?
3 potential complications include degenerations of the fibroids, which can lead to pain, necrosis of the fibroid tissue, urinary tract infections due to pressure on the bladder.
Good points, Rogers. Now, let us discuss management. Question 7. 3 marks. Could you broadly outline the management options for uterine fibroids?
Management options can be divided into medical and surgical approaches. Medical management may include mifepristone, danazol, GnRH agonists, GnRH antagonists, and the levonorgestrel intrauterine system. Surgical options include myomectomy and hysterectomy, depending on the severity and symptoms.
Thank you for that overview, Rogers. Finally, let us conclude with the definitive management. Question 8. 2 marks. What is the definitive management of uterine fibroids?
The definitive management of uterine fibroids is hysterectomy.
Thank you, Rogers, for your insightful contributions today. Uterine fibroids can significantly impact a woman's health, and understanding their management is crucial for effective patient care. That concludes our discussion for Season 3, Episode 5. We hope you found this dialogue informative. Thank you for joining us, and we look forward to seeing you next time.
Welcome to Season 3, Episode 6 of our Doc Scenario video series. In this episode, we will explore a clinical scenario involving a 17-year-old patient presenting with concerning symptoms during her first pregnancy. Our student, Rogers, will be answering key questions related to the diagnosis, investigation, and management of the case. Let's begin. The patient is a 17-year-old girl admitted to the labor ward at 37 weeks of gestation due to severe headache and reduced fetal movements. Upon examination, her blood pressure is recorded at 164/106 millimeters of mercury, and urine tests show protein levels of +++. The cardiotocograph, or CTG, reveals a baseline fetal heart rate of 249 beats per minute with reduced variability between 5 to 10 beats per minute, as well as variable decelerations and occasional accelerations. Rogers, based on this scenario, what is the diagnosis? 1 mark.
The diagnosis is severe preeclampsia, 1 mark.
Excellent. Now, how would you investigate this patient? Please outline your approach. 3 marks.
I would conduct the following investigations. 1. A full blood count to assess for anemia and thrombocytopenia. 2. Renal function tests to measure urea and creatinine levels. 3. Liver function tests to evaluate AST and ALT levels. 4. An ultrasound to check fetal presentation, weight, and heart rate. 3 marks.
Very thorough, Rogers. Finally, how would you manage this patient? Please detail your management plan. 6 marks.
My management plan would include 1. Admitting the patient to the hospital for close monitoring. 2. Initiating resuscitation as necessary, including fluid resuscitation. 3. Administering antihypertensive medications to control her blood pressure. 4. Starting magnesium sulfate for seizure prophylaxis. 5. Considering induction of labor if the patient's condition does not improve. 6. Delivering the baby when it is deemed safe to do so. 6 marks.
Thank you, Rogers, for your insightful responses to this clinical scenario. Your thorough understanding of the diagnosis, investigations, and management of severe preeclampsia is commendable. Thank you for joining us for Season 3, Episode 6 of Doc Scenario. We hope this discussion has been informative and will aid you in your clinical practice. Welcome to Season 3, Episode 7 of our Medical Dialogue series. Today, we will explore a clinical case involving a patient undergoing a procedure for the removal of retained products of conception. Joining us is Rogers, a dedicated medical student who will assist us in discussing this case. The patient, Mrs. Mabel Bwalia, is undergoing a manual vacuum aspiration for the removal of retained products of conception. She presents with a history of pervaginal bleeding, lower abdominal pain, and other concerning symptoms. Let's delve into the details of her presentation. Rogers, can you list the key features in Mrs. Bwalia's history that may indicate the need for this procedure? You have a total of 4 marks for this part.
Certainly, Doc. The key features from the history that Mrs. Bwalia may present with include 1. Pervaginal bleeding. 2. Lower abdominal pain. 3. Tiredness or weakness. 4. Loss of pregnancy symptoms, such as nausea and breast tenderness.
Great job, Rogers. Now, what about the examination findings? Please provide 4 features that may be observed during the examination.
The examination findings may include 1. Slight abdominal distension. 2. Tenderness elicited upon palpation of the uterus. 3. Active bleeding from the cervix, assuming it is dilated. 4. Absence of fetal heart sounds upon auscultation.
Excellent. Now, let us discuss the potential complications that Mrs. Bwalia could face following the procedure. What are the key complications to monitor for? You have another 4 marks for this question.
The potential complications following the procedure may include 1. Infection or sepsis. 2. Uterine rupture. 3. Heavy bleeding leading to severe anemia. 4. Damage to the cervix or vaginal tract, as well as the risk of incomplete abortion.
Well articulated, Rogers. Lastly, can you elaborate on the care that Mrs. Bwalia should receive after the procedure? This is worth 2 marks.
Of course, Doc. Post-procedure care for Mrs. Bwalia should include 1. Encouragement to rest and recover adequately. 2. Management of pain as needed. 3. Advising the use of pads for any pervaginal bleeding. 4. Instruction to avoid sexual intercourse, tampons, and douching to reduce the risk of infection. 5. Scheduling follow-up appointments for ongoing monitoring. 6. Monitoring for concerning symptoms such as increased bleeding, fever, or worsening pain.
Thank you, Rogers. Your insights have provided valuable information on the management of retained products of conception and the associated care. This concludes our discussion for today. Thank you for joining us in Season 3, Episode 7 of our Medical Dialogue series. Welcome to Season 3, Episode 8 of the Doc Scenario Challenge. In this episode, we will be discussing a critical case that highlights the importance of prompt assessment and management of a potential emergency. Let us consider the case of a 28-year-old woman who presents to the gynecological emergency ward with a history of amenorrhea for 2 months. A relative reports that she fainted at home just a few hours earlier. The patient has also experienced spotting for the past 3 days and is complaining of lower abdominal pain. Rogers, based on this scenario, what is the likely diagnosis for this patient? 2 marks.
The likely diagnosis is a ruptured ectopic pregnancy.
Thank you, Rogers. Now, what features will you look for in your examination to support this diagnosis? 4 marks.
In the examination, I would look for the following features. 1. Cervical motion tenderness. 2. Adnexal tenderness. 3. Absent uterine enlargement. 4. Signs of pallor. 5. Increased pulse rate. 6. Low blood pressure.
Excellent. Moving on, what 2 investigations would help in making the diagnosis? 2 marks.
The 2 investigations that would help in making the diagnosis are 1. Raised beta HCG levels. 2. An ultrasound, which may show an adnexal mass or an absent intrauterine pregnancy.
Very well stated. Lastly, what is the definitive management for this patient? 2 marks.
The definitive management of this patient involves several steps. First, we would treat the shock by administering Ringer's solution while simultaneously preparing for laparotomy and blood transfusion. Once stabilized, a laparotomy would be performed to locate the site of rupture, and if necessary, a salpingectomy would be conducted.
Thank you, Rogers, for your comprehensive answers. This case underscores the importance of timely intervention in managing ruptured ectopic pregnancy, which can be a life-threatening condition. Thank you for joining us for this episode of the Doc-Scenario Challenge. Stay tuned for the next episode, where we will explore another fascinating clinical scenario. Until then, continue to enhance your medical knowledge and skills. Welcome to Doc-Scenario, where we explore clinical cases and enhance our medical knowledge through practical dialogue. Today, we have a compelling case involving a patient with multiple gestation. Let us dive into the details. We have Mrs. Chu, a 30-year-old woman, who is currently pregnant for the 4th time and has 3 living children. She is 29 weeks into her pregnancy with multiple gestation and presents with painless vaginal bleeding that has persisted for the last 2 hours. Let us explore the potential complications and clinical features of this case. Rogers, can you list 8 complications that can arise from multiple pregnancies? This section is worth 4 marks.
Certainly, the complications that can arise from multiple pregnancies include 1. Postpartum hemorrhage 2. Preeclampsia 3. Uterine rupture 4. Preterm labor 5. Gestational diabetes mellitus 6. Placenta abruption 7. Polyhydramnios in the fetal side, we have 8. Malpresentation 9. Twin-to-twin transfusion syndrome 10. Intrauterine growth restriction 11. Locked twin syndrome 12. Non-immune hydrops fatalis.
Thank you, Rogers. Now, could you please elaborate on 12 clinical features you would elicit from this patient? This section carries 6 marks.
Of course, in terms of history, I would inquire about 1. Increased weight gain, which may be more than the normal rate. 2. Hyperemesis gravidarum. 3. Increased fetal movements. 4. Increased tiredness. 5. Increased frequency of headaches. 6. Shortness of breath. 7. Swollen legs. 8. Hemorrhoids. 9. Increased appetite. Upon examination, I would look for 10. A large foedates uterus. 11. A barrel-shaped uterus. 12. Palpation of multiple fetal parts. 13. Fetal heart sounds, ideally hearing at least 1.14. The presence of varicose veins. 15. Edema.
Excellent. Now, can you explain the possible cause of bleeding in this patient? This part is worth 2 marks.
The likely cause of bleeding in this case is placenta previa, where the placenta is located low in the uterus and partially or completely covers the cervix.
Thank you, Rogers. Next, how would you investigate this patient? This section is valued at 4 marks.
I would conduct the following investigations. 1. A full blood count to assess for anemia or infection. 2. Coagulation studies to evaluate bleeding risks. 3. Group and cross-match in case of possible transfusion needs. 4. An ultrasound to assess fetal well-being in the placental position. 5. Monitoring of fetal heart rate and heart sounds using Doppler. 6. RHA-B screening to determine blood type compatibility.
Well done, Rogers. Lastly, how would you manage this patient? This part is worth 4 marks.
The management plan would include 1. Immediate admission to the hospital for close monitoring. 2. Continuous monitoring of fetal well-being. 3. Determination of the cause of bleeding through further assessments. 4. Administration of intravenous fluids to prevent shock. 5. Use of tocolytics if necessary to manage contractions. 6. Administration of dexamethasone to promote fetal lung maturity. 7. Keeping the patient admitted until delivery is feasible.
Thank you, Rogers, for your insightful responses. This case highlights the complexities and challenges associated with multiple pregnancies. We appreciate you joining us for this episode of Doc-Scenario. Until next time, stay curious and keep learning. Welcome to Season 3, Episode 10 of the Doc-Scenario Challenge. Today, we will discuss a common screening test used in gynecology, focusing on its indications, precautions, disadvantages, alternatives, and management options if the results are positive. Let us dive into the scenario. Rogers, today we have a patient who has undergone a cervical screening. What is the name of this test? 1 mark.
The name of the test is the Pap smear.
Excellent. What is the indication for performing a Pap smear? 1 mark.
The Pap smear is used to screen for premalignant and malignant lesions of the cervix.
Great. Before conducting a Pap smear, what are 2 important precautions that should be taken? 1 mark.
2 important precautions include avoiding scheduling the test during menses and avoiding the use of creams or lubricants 48 hours before the test. Additionally, douching or using tampons should be avoided for 48 hours prior, and sexual intercourse should be refrained from 24 to 48 hours before the procedure.
Very thorough, Rogers. Now, can you name 2 disadvantages of the Pap smear? 1 mark.
2 disadvantages of the Pap smear include that it can be uncomfortable and embarrassing for the patient. Additionally, there is a possibility of false positives or false negatives if the slide is not prepared properly, and the test could be expensive.
Thank you for that. Moving on, what are 4 alternatives to the Pap smear? 2 marks.
4 alternatives to the Pap smear include HPV DNA testing, colposcopy, visual inspection with acetic acid, VIA, and visual inspection with Lugol's iodine, VILI, as well as liquid-based cytology.
Excellent. If the Pap smear results come back positive, what would be the next course of action, and what treatment options could be offered to the patient? 4 marks.
The next course of action depends on several factors, including the patient's age, desire for reproduction, risk factors, and the degree of dysplasia. Treatment options include observation with repeat smear, HPV testing, or colposcopy within a year. Local ablation techniques such as cryotherapy, electrosurgery, cold coagulation, and laser vaporization can be considered. Excisional methods like LEEP or conization may also be appropriate, and in some cases, a hysterectomy might be indicated.
Thank you, Rogers, for your insightful answers. You have provided a comprehensive overview of the Pap smear and its implications. That concludes our discussion for today. Stay tuned for more episodes in the Doc Scenario Challenge.